Is the screwworm outbreak actually a threat to your food? How have cuts to our nation's food infrastructure made our food supply less safe and endangered our health? In this episode of Care Talk, Dr. Carrie McMahon, a former FDA regulatory scientist with over 2 decades of experience, now a contributor to Unbiased Science, cuts through the noise and delivers unbiased, evidence based answers. Welcome to Care Talk Live, a weekly American healthcare policy show and podcast where we explain how healthcare works or doesn't work and get you answers. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Be sure to subscribe to my channel or podcasts wherever you get your podcasts to get future Care Talk shows. The New World screwworm has officially been confirmed in the United States, prompting emergency animal health declarations across the Southwest. Federal agencies say the food supply is safe, but what does this outbreak mean for livestock and for your grocery bill? Dr. Carrie McMahon is the owner of Feed My Mind Regulatory Consulting LLC and a contributor to Unbiased Science. So, welcome, Dr. Carrie.
Laura, thank you for inviting me today. This is really a pleasure to come and speak with your audience and try to answer some questions.
Thanks. Well, let's start with the most basic question, which is, what is a screwworm and why should we care or not care?
Sure. Let me start with something people maybe are more familiar with, and that's a butterfly, right? So we know that butterflies come from caterpillars. Well, the screwworm comes from the screwworm fly. So the screwworm itself is the larval or juvenile stage of this fly. What's really unique about it is that its food source is live tissue. So the mama fly deposits her eggs in wounds or the soft tissue of animals. And this is how the fly gets to its food source, the larval stage, and it's able to grow and reproduce.
That sounds pretty horrific. So these worms are burrowing into wounds and turning into flies. So we knew this was coming, right? Like this has slowly been making its way to the United States, but hasn't gotten here yet.
That's correct. So at least as early as 2022, 2023, scientists and ranchers and government officials who've been monitoring the screwworm have noticed that it's been tracking northward. Now, the screwworm fly is from South and Central America. And in the early days before 1960, in the last outbreak, we had been able to manage this screwworm fly, keeping it contained down in Central America with the help of the Panamanian government and the Mexican government. But like a lot of nature, it's been finding its way northward, and it finds its way as kind of a hitchhiker, and it hitchhikes on animals. And those animals have been coming up from Central and South America. And now the flies are laying eggs in 27 cases, at least so far in the last 30 days, in animals in Texas and New Mexico.
So if you're a farmer in Texas and New Mexico, any of these states that border New Mexico because it's coming north, what happens? Say you have a cow and it has a screwworm, then what?
Well, monitoring is really the first step. And so ranchers and farmers are going to be looking closely at their herds in this area. And they're going to look for wounds that aren't healing, that are festering, or maybe it's in the mucous tissue like the eyes or the nose. And as soon as they notice this, they're going to start to want to clean out that wound and get rid of all the eggs and the larvae. They're going to want to also keep that animal contained in a way to prevent movement, not letting it into the food supply, letting regulatory officials know so that they can then go and make sure that there's no spread of those eggs and the larvae.
So, does this pose a danger to Americans? Has it entered our food supply, or will it, or what happens?
So this isn't a food safety concern. It absolutely is an animal health concern. It's a food production concern because if you have sick animals, you're going to have to take care of them, and they might be smaller and not make it into the food supply. It's an economic consideration. The US is at a 75-year low in cattle production. And so this is going to further hurt our cattlemen. And they're not going to have the cattle to produce. And that's an economic concern for all of us, right? Because that's going to hit our pocketbooks. And you can already see that happening with the rises in the beef prices. It's been rising in part because of the US cattle and beef production, but also because the US has been closing the border with Mexico, which is another source of the beef that we get.
So if you are not a farmer and this doesn't affect you directly, the way that many Americans will be affected indirectly is that beef in grocery stores will get more expensive and harder to get.
That could indeed be the case. As supply goes down and demand stays the same, costs go up. And it's going to also be very labor intensive and costly for the rancher, right? Because as you asked earlier, they're going to have to do something, monitoring their herd closer, treating their herd, bringing in veterinarians. They may have medications to treat the animals as well as taking care of those wounds to make sure they heal. So this is going to be kind of an economic catch-22 that's going to, it's going to impact a lot of us for a long time.
And let's talk about the why, in that we knew that the screwworm was making its way north, and you mentioned monitoring and systems in place that American scientists and research, we were trying to be proactive, pay attention to the problem, come up with solutions before it got here. But I have read that one of the main programs that was aimed at combating the screwworm, in particular, the screwworm, was cut by DOGE last year. So can you talk more about that?
I can talk about the government oversight of diseases and pests coming into the country. And I can say that this is really something that all administrations have to deal with when they're planning their budgets. And when you plan a budget and you get it right and you tackle the things that are of the greatest risk, nothing happens. And so to the public, this looks very much like there's no problem here. And so for many years, it looked like there's no problem here. But the moment we take our eye off of nature, nature finds a way. You may have heard this before, nature finds a way. And the numbers had been increasing during previous administrations and then into the current administration. And there were cuts to groups like APHIS, that's USDA's Animal Plant Health Inspection Service, their Food Safety Inspection Service as well, and to the budget of some of the monitoring programs. And this all came at a time when we knew, scientists and farmers knew, that there was an increased risk. Every government, every administration has to do their best to figure out which risks are the most important ones. And it appears that this administration may have missed that signal that this was a really important one, while it was looking at other things that it maybe prioritized at a higher level.
Yeah, going back to the cuts that DOGE made, this is what happens when expert research is cut by people that don't understand the problems that the research is trying to solve, or how basic research works. So can you speak about how our food supply, whether it is less safe because of some of these public health cuts?
I don't think at this time that it's less safe, and I don't think that people should panic. There are still thousands of civil servants working in federal government, applying the best science they can to try to ensure that food remains safe. Now, are they working at reduced capacity because there are fewer staff? I can say from my own office at FDA, yes. Are they working with less resources? Yes. And so I think the challenge is over time, how tight can you stretch the resources in the budget? We all have household budgets, right? We all have to figure out how much money to spend on the lights. How much money do we spend to put gas in the car? How much money do we spend when we want to go out to the movies and get popcorn, right? Or something extra. the government has to do the same thing. And one of the challenges is that when they do it well, we don't see anything happen. And so sometimes we might take that for granted. And as an FDA employee, I often felt taken for granted, taken for granted, like all the hard work. Um, it's important to remember when you don't see food safety problems, there's a lot of people behind the scenes trying to make sure that you're safe and healthy. So when it's time to vote, vote. Make sure you're voting for people who are going to fund things you think are important, like public health, like your family's health, like food safety and food security.
And also, for everybody listening to this, if you are an American, you are represented by two, except for people in Washington, D.C., you're represented by two senators and one representative, and they need to hear from you because right now Congress is working on a budget. And so Congress is determining how much that agencies, including the FDA, get for their work and what to prioritize. One of the things that's so offensive to me personally about Doge is that these kids were cutting things that they didn't understand, and they taking the determination of budgets out of Congress's hands, which is their job, what we pay them for, and giving it to these unelected kids that now we're seeing the repercussions, of the screwworm research that was canceled, that they thought, oh, I've never heard of a screwworm. Sure, we can get rid of that. But it turns out that all these things that you haven't heard of, there's a reason why you haven't heard of it.
Yes.
And that's because of dedicated scientists, doing the research, making sure these bad things don't happen.
Laura, absolutely. I can tell you a story if that's okay. And
Sure.
that story is that last year, when the current administration was making their cuts and trying to make a more efficient and nimble government, some of the staff they cut were asked to come back while on administrative leave and work while they were supposed to be at home not working, because what they did was so critical to public health that the administration quickly realized we're in trouble if these people don't come in and work. And so I personally know several people from my office who were told, go home, don't turn your computer on. Oh, by the way, please turn your computer on. And it speaks to the dedication of a lot of these staff, because many of them said, yes, okay, I'll do that.
Mm-hmm. And thanks again for joining us. Are there any reputable sources that people should go to if they have concerns about the screwworm in particular, or the safety of our food supply in general? Where should people be getting their news about this?
I always think it's really great to come to forums like this, to people that we trust and that put a lot of effort into bringing the facts forward. Unbiased Science is a group that I volunteer with because I believe that they're doing their very best to bring the science so that their readers can make informed decisions. It's one of my taglines is that to make good decisions, we need to start with good information. So I would really encourage people to find those sources of good information, like Unbiased Science. People who aren't selling a product, they're just trying to provide information to you, and they're willing to listen to any voice. That means they're really interested in being unbiased.
Well, thanks again for joining us, and thanks for the work you do.
Thank you so much for this opportunity.
And a reminder to our audience that we have free or low-cost healthcare resources available on our website at healthcarevoices.org/care talks. So check it out. And please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. And now our experts will answer your health insurance questions. So welcome to Louise Norris, Health Insurance and Healthcare Reform Analyst at healthinsurance.org, and Diane Archer, founder and president of Just Care USA. So let's start with Diane, who has some news on Medicare reform.
Thanks, Laura. Yes, I have some fairly happy news, which is always good. And that is that the Senate Democrats have been working together on how to make healthcare more affordable. And in this particular instance, how to make healthcare more affordable and accessible for people with Medicare. And what they've done is collectively 15 Senate Democrats, led by Senate Finance Committee Minority Chair Ron Wyden, introduced a reform that a lot of experts believe is the most important Medicare reform that could be passed. And that would add an out-of-pocket limit to traditional Medicare. And why is that important? It's important because it would give people a true choice of traditional Medicare and not only Medicare Advantage. So right now, let me explain. Millions of older and disabled Americans don't have the ability to enroll in traditional Medicare. They can only enroll in Medicare Advantage because of the fact that traditional Medicare lacks an out-of-pocket limit. So if they're in Medicare Advantage, every year there's an annual open enrollment period, but they're effectively locked into Medicare Advantage because supplemental coverage they need to protect themselves financially in traditional Medicare is either unavailable to them or unaffordable to them. What do I mean by that? Well, traditional Medicare has 20% coinsurance, and without an out-of-pocket limit, if you get really sick and need a lot of care in traditional Medicare, you could have to pay 20% of $1 million, which is just insanity. Nobody can really afford that, or very few. So this out-of-pocket limit that the Senate is proposing in its bill would cap people's out-of-pocket costs at $5,000 a year. Still high, but at least manageable, and would mean that people would not have to have supplemental coverage if they wanted to be in traditional Medicare. So it would allow people to enroll without financial worry. The other good thing about this out-of-pocket cap is right now, Medicare Advantage plans basically don't have to worry about people leaving. People can't leave in many instances. So because you're locked in, because you can't take the risk of being in traditional Medicare. So the out-of-pocket cap would actually drive some competition in the Medicare marketplace. And ideally, it would get the Medicare Advantage plans to do better, to deny care less often, delay care less often, because they know that if they don't do right by their enrollees, the enrollees would be able to leave. So this is all great news. The question is, how long will it take for this bill to pass? And that, unfortunately, we still don't know the answer to. It will depend in no small part on the outcome of the next election in 2026 in November, and then in 2028. So not likely to pass before 2028, but fingers crossed. As of then, maybe we can have this limit in traditional Medicare.
Thank you, Diane. And over to Louise. CMS, the Center for Medicaid and Medicare, put out a report about Affordable Care Act enrollment. So tell us about that.
Yes. So we already knew that enrollment in the marketplaces was down this year after the marketplace subsidy enhancements expired at the end of 2025. During open enrollment, there were 23.1 million people who selected plans, and that was down from 24.3 million the year before. Every year, including during the years when those subsidy enhancements were in place, there's a drop off between the number of people who sign up during open enrollment and the number of people who actually pay their first month's premium and have coverage in force. There's always a decline there. This year, so the report that CMS just put out last week, the effectuated enrollment, which means people who actually paid their first month's premium and have coverage in force, as of February of this year was 19.2 million people. So compared with last year, year over year, from February to February, that's down about 12% from 2025. But it's surely lower now because that was February. We're now at the end of June. People whose coverage was automatically renewed for 2026, if they were getting a subsidy, which most people were, they actually had a 3-month grace period, January, February, and March. And so their coverage, if they just didn't make any premium payments in 2026, didn't actually terminate till the end of March. So we know that that 19.2 million figure is an overreport at this point, but we don't have any additional data. And I think, you'll see a lot in the news about this report. CMS in the report very heavily focused on the fact that this disenrollment is all just the result of mitigating fraud and improper enrollments in the marketplace, which, to be clear, I'm not downplaying that. The Biden administration stepped in 2024 and addressed the fact that they knew that there was a significant problem with people being enrolled in plans they didn't know about. Fraudulent enrollments, that was definitely an issue that the Biden administration started tackling. And not to downplay that, we definitely need to address that. But we also know that a lot of people canceled their coverage or weren't able to keep making their premium payments this year simply because their premiums got too high. KFF did an analysis earlier this year, found about 1 in 6 marketplace enrollees said they weren't sure whether they would be able to continue to pay their premiums. Obviously, these were people who knew they were enrolled, were properly enrolled, were not fraudulent. They just were looking at the premiums and said, I don't know if I can keep on paying this. Net premiums went up about 58% in 2026 after the subsidy enhancements expired. And that happened even though a significant number of people switched from silver plans down to bronze plans, which are cheaper as far as premiums go, but have much higher out-of-pocket costs. So there's a significant issue with affordability of these policies. People who earn more than 400% of the poverty level lost their subsidies altogether. In some cases, their plans went from being, a few $100s a month to a few $1,000s a month. It's not surprising if somebody in that situation decides they can't keep their coverage because they literally cannot pay the premiums. So when you see these numbers, when you see 19.2 million people with marketplace coverage, first of all, know that that's at this point an out-of-date number. It's from February. And also that this is certainly not all caused by just, working out the issues with unauthorized enrollment. There are also a lot of people who can't afford their coverage this year, and that's part of the reason enrollment is dropping.
Thanks, Louise. And I mean, personally, my coverage went up 21% a month. I'm paying 21% month or more every month. And I can afford that. I'm making that work, but many people can't afford a 21% increase in their health insurance, and they just have to drop their policy.
Absolutely.
So
and a lot of people saw really, hundreds of percent increase in their premiums. So it was a significant affordability issue this year.
Absolutely. And it's not going to get better. It's just going to get worse from here.
Right. There's no, it could change. We could see, after the election, depending on the makeup of Congress, the issue of affordability of marketplace plans could be revisited. But the way things stand right now, as we head into open enrollment in the fall, there's nothing being done to mitigate the fact that this self-purchased coverage is less affordable than it was.
And we got a comment from Victor on YouTube from our last episode, who said that I got Medicaid, and once they took me off Medicaid, claiming I earned too much, but I later reapplied and got it back. So good for you, Victor. And Louise, do you want to talk about how Medicaid eligibility works?
Yes. So this is not uncommon. The thing about Medicaid is it doesn't have an annual open enrollment period. You can apply anytime during the year. And if your situation changes, you may be eligible for Medicaid now, even though you weren't 2 months ago. So, depending on what Victor's circumstances were when he lost his Medicaid, it may have been that his income had temporarily gone up. If his income then drops, they can do your Medicaid eligibility based on your current monthly income. They can also look at annual income. If your current monthly income is too high, they can look at annual income. But if your current monthly income drops to 0 or drops low, it doesn't matter what you were earning in previous months of the year. You can still enroll in Medicaid. You can apply anytime, and if you're approved, you can sign up. So circumstances change. Just know that you can apply to your state Medicaid agency anytime during the year, and if your circumstances have changed, even if you just applied a few months ago and got denied, you might be eligible now.
Thanks, Louise. And back to Diane. Nightcap on Reddit says that their surgeon has opted out of Medicare, and I have Blue Cross Blue Shield supplemental. Blue Cross says they will pay for my surgery anything over what Medicare would have paid if they had issued a payment. But I don't know how much Medicare would pay, and Medicare won't give me an estimate of how much they would pay without me providing the procedure code. Diane, want to help us with what's going on here?
Yes, I think I can explain what's going on, and it's not good news here because the way Medicare works is that if Medicare is covering a service, then supplemental coverage will pick up the 20% that is not paid by Medicare for Part B medical services. But if Medicare is not paying for a service, then supplemental coverage is not going to pick up the cost, even if Medicare would have picked up the cost of the service. So let me just step back for 1 second and explain that Medicare basically is a program where more than 90% of doctors take Medicare. So you should be able to find a doctor through your local hospital or health clinic who takes Medicare for the services you need. In some instances, you can't, but when you can, you must, because going to see a doctor who has opted out of Medicare effectively means that that doctor has decided that the doctor is not going to bill Medicare for the service. And the doctor must require you to sign a waiver, putting you on notice that Medicare will not be billed for the service. And once you've signed that waiver, you are responsible for the full cost of the service, both the part that Medicare would have paid had you gone to a doctor who took Medicare, and the part that your supplemental insurer would have paid if Medicare had paid. So I'm sorry to say that unless you have some special insurance that I have never heard of, there is no way to collect from your supplemental insurer for a procedure that Medicare is not paying for.
Thank you, Diane. And as you said, perhaps they can find another doctor.
Exactly.
Well, thank you, everybody, for joining us today to learn more about healthcare policy, patients' rights, the fight for a just healthcare system, and answers to your questions on health insurance and healthcare. Be sure to check out more free or low-cost healthcare resources on our website at healthcarevoices.org/caretalk. And please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more, and be sure to subscribe to my channel or podcast wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.